stem cell disorder resulting in proliferation of all the hematopoietic lineage but manifesting predominantly in granulocyte series. Okay, so if we move to the first particular diagram, we will see that this is the lymphoid progenitor and this is the myeloid progenitor, and this is going to make all kinds of cells: red cells, platelets, neutrophils, basophils, eosinophils, and monocytes. But they are saying that this is manifesting predominantly in the granulocyte series. So these are the granulocytes. Okay. Okay, then we have lymphoid progenitor cells. They are going to produce B cells and T cells. B cells and T cells के लिए हमारे पास अलग ही वो है classification, that is lymphoid leukemia. यहाँ पे हमारे पास हम अभी बात कर रहे हैं myeloid leukemia की. lymphocytic leukemia पे हम बाद में बात करेंगे. Okay. Okay, so maturation of the cells proceeds fairly normally. Disease occurs chiefly between the ages of 30 to 80 years, with peak incidence at 55 years. It is rare, with an annual incidence in the UK of 1.8 per 1 lakh and accounts for 20% of all leukemias. It is found in all races. Defining characteristics of CML is the chromosome abnormality known as Philadelphia chromosome. This is a shortened chromosome 22 resulting from a reciprocal translocation of material with the chromosome 9. The breakpoint 22 occurs at the breakpoint cluster region BCR. The fragment from 9 that joins the BCR carries the ABL oncogene, which forms a fusion gene with the remains of BCR. Now this BCR-ABL fusion gene codes for a 210 kilo DA protein with the tyrosine kinase activity, which plays a causative role in the disease and oncogenesis. ठीक है? Okay, influencing the cellular proliferation, differentiation and survival. बना लेते हैं. Okay, in some patients in proliferation, differentiation and survival. In some patients in whom the conventional chromosome analysis does not detect a Philadelphia chromosome, BCR-ABL gene product can be detected. Okay, so now a variation is that if we cannot find the chromosome, we can find the gene product by molecular techniques. Next up, we have the natural history. The disease is going to have 3 phases. A chronic phase, in which the disease is responsive to treatment and is easily controlled, which used to last 3 to 5 years. With the introduction of imatinib therapy, this phase has been prolonged and encompasses a normal life expectancy in many patients. So it has 3 courses. First of all, it can be a chronic phase. Then there is an accelerated phase. Accelerated phase is not always seen because it's very fast. If the disease control becomes more difficult and there are more primitive cells in this particular phase. And then it is converted into blast crisis, in which the disease transforms into an acute leukemia, either myeloblastic or lymphoblastic. Okay, so now although this is myeloid, but it can be transformed into myeloid or lymphoblastic leukemia, which is relatively refractory to treatment. This is the cause of death in the majority of patients. Survival is therefore dictated by timing of blast crisis, which cannot be predicted. Prior to imatinib therapy, approximately 10% of the patients per year would transform in those treated with imatinib. For up to 10 years, only between 0.5 to 2.5% have transformed each year. So now with imatinib therapy, there is less transformation. Then we have the clinical features. In CML, if we have to pick it out of all the others, we are going to see that this patient will have splenomegaly. No other leukemia will be as eager to mention splenomegaly except for this leukemia. it will be a trademark to see splenomegaly over here. Symptoms of the presentation may include lethargy, weight loss, abdominal discomfort, gout from too much death of the cells, and sweating. About 25% of the patients are asymptomatic at diagnosis. Splenomegaly is present in 90%. In about 10%, enlargement is massive, extending over 15 centimeters below the costal margin. Friction rub may be heard in case of splenic infarction. Hepatomegaly occurs in about 50% and lymphadenopathy is unusual. Okay, so now the investigations. In investigations, we are going to find full blood count results are variable. There is usually normocytic normochromic anemia. Leukocyte count can vary from 10,000 to 600,000. In about one third of the patient, there is severely high platelet count, sometimes as high as 20,000. In the blood film, full range of granulocyte precursor forms of myeloblast to mature neutrophils are seen. Okay, on the blood film, we are going to see granulocytes and the precursors from myeloblasts to mature neutrophils. But the predominant cells are neutrophils and myelocytes. Myeloblasts usually constitute less than 10% of all the white cells. There is often an absolute increase in eosinophils and basophils, but it will be predominantly neutrophilic. And nucleated red cells are common. If the disease progresses through an accelerated phase, the percentage of more primitive cells increases. I told you, if there is a blast crisis, accelerated phase, there will be the primitive cells. Over here it is mentioned primitive cells in accelerated phase. Okay, blast transformation is characterized by a dramatic increase in the number of circulating blasts. The patients with thrombocytosis, a very high platelet count, may persist during the treatment in both chronic and accelerated phase, but usually drop dramatically at blast transformation. Basophilia tends to increase. Okay, so now full blood cells, and we are going to look this under a microscope on a blood film. Then we'll go and see the bone marrow. Okay, bone marrow should be obtained to confirm the diagnosis and the phase of disease by morphology. Chromosome analysis to determine the presence of Philadelphia chromosome. Bone marrow करें आप, chromosomal analysis करें to determine the Philadelphia chromosome, and RNA analysis to demonstrate BCR-ABL gene product. Blood LDH levels are elevated and uric acid levels may be high, but lab score is decreased because all the neutrophils that are working here, they are not the good neutrophils. They are not going to kill anything. Lab score is increased. Lab score is increased when the leukocytes are fighting. They are working in increased WBC. In CML, WBCs are immature, useless cells. Thus, there is no increase in lab score, although white blood cell count is increased. What will be the management in chronic phase? Okay, मैनेजमेंट में सबसे पहले तो हमने ये देखना है टायरोसिन काइनेज इनहिबिटर्स. फर्स्ट लाइन इमेटिनिब, dasatinib, nilotinib. Second line imatinib, nilotinib, dasatinib, pontinib. Okay. Outcomes say 90% achieve complete cytogenic response. Response faster with nilotinib and dasatinib. Median survival comparable to normal population.